fabulous to see so many people here today to talk about aging speciality research. Okay, let me just. Sorry. Got lots of faces and popping into my screen. Are we? Can everyone see the slides?
Yeah.
Yes. Thank you. Okay, so we're here for two reasons really. One, to celebrate the work that has been done within the aging speciality. I should introduce myself first, shouldn't I? So hi, I'm Debbie. I'm the chief investigator on an aging speciality portfolio project. So it's the largest project on the aging portfolio, and actually on the National NIHR portfolio as well. So we're here today to celebrate that kind of aging community speciality of researchers who've worked to deliver that project. And so CHARMA itself is actually internationally so I'd said it's really big in the portfolio locally, but internationally it's the largest hospital deprescribing trial. And the fact that it's then dedicated to older adult population, I think is brilliant. It's really exciting. So we're here to celebrate the work that's been done around that, but also to actually nurture that community that's formed around that project, so that we can think about how we can further grow research capacity within the older adult speciality. So I thought there may be some here who are perhaps unfamiliar with CHARMA, and it would be useful to just give you a really quick overview. So CHARMA is a multidisciplinary team-led intervention to help address the problem of inappropriate polypharmacy. It's mainly a collaboration between geriatricians and pharmacists to support them to identify and then proactively deprescribe medicines with the potential to cause more harm than benefit before any harm occurs. And with CHARMA, there were two things that we're looking to achieve. So we were looking to reduce unplanned hospital admissions by reducing the number of inappropriate medicines that older adults are prescribed whilst in hospital. And CHARMA itself has actually been a fairly long journey. It's been 10 years. So it started back in 2015 when we established whose behaviour we wanted to change, and we decided we would focus on geriatricians and pharmacists. What we then did is we established what we wanted them to do differently, and what we wanted them to do is obviously continue to reactively deprescribe medicines that are thought to be causing harm. So, for example, stopping medicines that harm the kidneys if someone's admitted to hospital with kidney damage. We obviously needed that to continue happening. And the new thing that we wanted them to do more of is proactively identify medicines that might not be doing any good and have the potential to do harm, and then stop those before harm occurs. And the reason we wanted to do that is because we know that 1 in 2 older adults who are admitted to hospital prescribed a medicine that probably ought to be stopped. So we then did some work over a period of time and developed the CHARMA intervention. And that ended up with 5 intervention components to facilitate geriatricians and pharmacists to proactively deprescribe medicines in hospital. We then did some small-scale testing, and some of you are here today who were involved in helping us do that. And then we've finally moved to the definitive trial, which takes us to 2025, which is where CHARMA has now finished that main part of its journey. So I mentioned there are 5 bits to CHARMA, so 5 things that we needed our sites to implement. And here the 5 things are. So there was an action plan that they needed to implement to indicate that proactive deprescribing is an organisational priority. There was also a workshop for pharmacists to help them think about the pros and cons of continuing to prescribe medicines that actually are likely to be inappropriate versus deprescribing them in hospital. There was also a workshop for geriatricians, and this was focusing around a belief that actually patients and family members would rather you didn't mess with the medicines when in hospital, when actually some underpinning work that we did said, oh my goodness, if we're prescribed medicines where the chance of harm outweighs benefit, we absolutely want you to stop those. There were then benchmarking reports that our CHARMA sites needed to implement. So that's where geriatricians and pharmacists could actually see their efforts to deprescribe there in black and white on these reports and compare themselves against other hospitals. And then the final component was weekly briefings between geriatricians and pharmacists, and that was to allow for more collaboration around deprescribing so that we could get pharmacists and geriatricians physically together at the same time to talk about opportunities. So that was what our sites needed to implement. And so the definitive trial had 24 sites in it, and they were distributed across the country. And I've kind of already alluded to it, that, the CHARMA intervention had 5 things to implement, and that was all within a trial environment too. So our local CHARMA teams at these 24 sites really did, it was a big ask of them. So each of the 24 CHARMA sites had a principal investigator, and that was either a geriatrician or a pharmacist. So really what I want to do here is to be able to say a huge thank you to those geriatricians and pharmacists who were principal investigators, because what you did, and I don't know if you probably haven't seen this, what you did is you recruited 143 geriatricians and 91 pharmacists, and that is an amazing achievement. And participating geriatricians and pharmacists, I know some of you are here today. Thank you to you for participating, for giving up your time to engage with the intervention, completing the questionnaires that we gave you, providing interviews so that we could understand what did and didn't work with the intervention and the trial. This is a really huge achievement for an ageing portfolio study, so thank you. Principal investigators, not only did you do that amazing job with recruitment, you entered research data for us, you secured a project manager who would oversee the implementation of CHARMA, you contributed to action plan launches. I mean, the list goes on in terms of what you did. So I cannot thank you enough for making CHARMA a reality. Project managers. So I don't know if we have any with us here today, but CHARMA was peculiar as an intervention. We talk about complex interventions, but it was almost like implementing a quality improvement project. So from the feasibility work, we learned that PIs needed additional support, so they went, identified project managers, and it was the project managers that made the CHARMA intervention a reality. And actually some PIs I know also took on project management roles, so really I'm so grateful to all of you. So the project managers, you did things like you basically coordinated implementation. And you were entering data throughout the 3-month implementation period, so we knew how you were progressing with implementation. You attended weekly community of practice meetings with Health Innovation East. At those, you generously kind of shared your expertise between sites, and you drove implementation of the CHARMA components. So the action plans, the workshops, all of that happened because of the work that you did. And as I said, I think this is really cutting edge in terms of trial design. So making that happen within, an environment where we know service delivery is challenging in itself is brilliant. So thank you so much for the fantastic work you did. And last but certainly not least, the research delivery team. So you did this small bit called enrolment and consenting of patients. And when we set out with CHARMA and trying to secure the funding, I remember they were saying, oh, you know, this is a very ambitious number of participants. This is what you did. For over 40,000 older adults were enrolled, over 1,000 were consented and data collected for them. But it's phenomenal. And that's what's made CHARMA the biggest portfolio study. And as I said, for that to be in the aging speciality is just amazing. So thank you. Thank you to everybody that's contributed. So amazing stuff has happened. However, this has really been driven by individuals. So this is personal effort over and above, in many cases, over and above your clinical service delivery, your usual role. And that's not necessarily the case in other disciplines. So older adult research is being driven by personal effort and the dedication of the few. And I think what we need to do is move to a situation where actually within your organizations, older adult research is valued, it's integrated into work plans, and therefore it's a sustainable model. And I think that's one of the key things that I would really like to be able to work with you to drive over the next few years. And with that, I'm going to hand over to Victoria.
Thank you. Do you want me to share my slides? How is that? Can you see my slides, everyone? Yeah, is that good? Okay, so thank you, Debbie. That was a really inspiring introduction. I feel slightly like I can't follow that in a way that does it justice, actually. What an amazing achievement by everyone. But I wanted to give a bit of background. I'm an academic geriatrician. You can see from the slide here that I'm currently based in Exeter. But I've meandered around a bit. So within the specialty, I actually started my clinical academic career in Southampton as an NIHR academic clinical fellow as a registrar. And then I went off to Cambridge on a Wellcome Trust funded PhD, and then was able to consolidate my academic work as a consultant through an MRC grant before moving to Exeter more recently. And in my meanderings about, I was very lucky to meet Debbie Bhattacharya, and Debbie invited me to be co-applicant on the CHARMA study, which is why I'm here today. And at the time Debbie was asking me about being a co-applicant on the CHARMA study, I was thinking a lot about inequity in healthcare, that sort of difference between different groups within the population in terms of their health outcomes, in terms of how they use the healthcare system and the resources, and that those differences that might be deemed to be unfair, unjust and avoidable, like those differences in healthy life expectancy between socioeconomic groups. And Mike Vassalli put that much more comprehensively than I'm able to do in these few minutes today in an editorial on Age and Aging, where he also said that actually inequity in research might be inadvertently exacerbating inequity in healthcare. And that was inspired by a systematic review in the same journal edition of rehabilitation interventions after hip fracture, which noted that of all the trials they reviewed, the majority of them excluded patients with cognitive impairment, despite 1 in 3 patients being admitted with a hip fracture having cognitive impairment. So it's really just highlighting that disparity between the patient population that we're treating at the coalface and in some cases the research participant population informing the evidence to develop those services. And if we're committed to providing evidence-based care, if we have certain groups in the population who are having a lower participation in research, we're not going to develop the treatments and services which might best optimise their outcomes. they'll have worse outcomes and be further marginalised. And then these sorry, there's a bit of interference there. So, and then this sort of negative cycle will continue.
I've just managed to paint my thing.
Can we mute whoever that is? Lovely. Okay, we'll have a sort of this sort of negative cycle will continue to go round. And obviously what I saw with the CHARMER study that Debbie has just really exemplified in her presentation was this big opportunity to address that underrepresentation amongst older adults in really a large and comprehensive programme of research. And at the same time, the RCP, Royal College of Physicians, and NIHR made a joint statement, making research everybody's business, really building on evidence that if you are research active as an institution, it improved outcome for all patients, not just those directly involved in the research projects themselves. It sort of lifted outcomes for everybody. And similarly, there was evidence that actually it made for a happier workforce, a more fulfilled workforce. So again, as Debbie's exemplified, it's not just about the patients, but also those of us who are looking after them. Being part of research has benefits for us too. So all clinicians, and I mean that in the broadest sense of the word, actually, not just doctors, but anybody looking after patients in a health or social care capacity can play a role in clinical research. We obviously need brilliant innovators like Debbie to lead these big programs of research, but we also need people equally important to actually deliver that research on the ground, recruiting those patients into trials and other types of research studies. And Debbie's referred to the national portfolio of studies, now called the Research Delivery Network, but previously known as the Clinical Research Network. And this is data just from a few years ago when it was called the CRN. We've got really good engagement across NHS trusts and GP practices, recruiting large numbers of participants into large numbers of portfolio studies. So that's all really good. But as Debbie's exemplified, when you drill down to the details, relatively few proportion of those participants were actually recruited to studies with ageing as a named specialty, and an even smaller proportion with ageing as the primary managing specialty. And that's exemplified a bit more here in this sort of graphical representation where you see the predominance of cancer studies amongst the portfolio of studies and the relatively fewer number of ageing studies at the bottom. And you might think, well, older people, they're going to be in the cancer studies. Older people get cancer, they get neurodegenerative conditions, they get respiratory conditions. Surely they're just represented in these other studies. But the soon to be published and long awaited NIHR Year of Birth project is revealing otherwise. And this was data that was given to me by the project lead, Shamila Anwar, a couple of years ago. This was preliminary data at the time, but it makes the point. If you look at research participants in cancer studies by their year of birth and look at that age distribution, that's the red bars. They sort of peak around 60 to 64 years old, whereas the blue line is the incidence of cancer in the general population by age, and that peaks some decade later, around 70 to 74 years. So again, coming back to my first point, you have this disparity between the participants in our research and the patients that we're treating at the coalface. And Debbie's already alluded to what might the solutions be, capacity building. So clearly we need the clinical academics to innovate, develop and lead the research, but we also need people on the ground to deliver that research, because if we don't, we're not going to reach those harder to reach populations and be more inclusive, building on infrastructure like NIHR Include to help recruitment and participation in research for those underserved populations. And so maybe our talks are the wrong way around, because Debbie's shown how it can be done. But now what we don't want to do is lose that momentum. And it's really good to present today just to kind of give that background and see how we can move things forward. So I'm going to stop there if I and stop sharing.
Thanks, Victoria.
There we go.
And I think we now have a short presentation from Jenny. Yeah.
Yes, hello everybody. I'm Jenny Griffiths. I'm a member of the CHARMA Patient and Public Involvement team. I'm also a member of the Ageing Society that we're talking about. And I'm just going to talk briefly about the involvement of the public in research. I joined CHARMA in 2021 and joined the research world as a patient and public involvement representative in 2012 when I retired. And I've used my lived experience of supporting family members with various different health issues. Thanks. For those that are not aware, PPI, or patient and public involvement research, is where members of the public and carers and patients work with researchers to design and conduct and disseminate studies. This is rather than being a participant in the research. Now, this helps to ensure that the research is relevant and the outcomes have the impact on communities that's desired. With today's ageing society, research is more important than ever, and involving older people means that you get an insight into their needs and their lived experiences from the outset and through the study. Thanks.
So we're struggling to manage.
So inclusion of representatives at the design stage is very important, because that helps to set the objectives of the study. This is very useful. It's often at pre-funding stage, so they may not go on to be in the team that supports the research. But then throughout the research, PPI members can provide advice and help with participant recruitment. They can advise on the means of communication with patients, including those with impairments such as sight and hearing issues. They also can contribute to the dissemination and planning and identify appropriate organisations and publications that older people are likely to be looking at and reading. Now, the rapid increase in technology and also with the multicultural society that we have today, these can all be barriers to recruiting people to PPI. And it's important to have those people, because the people that you have on that group need to be a reflection of the communities that the research is going to serve. Otherwise, it can be skewed, you can be going down the wrong route. So that's extremely important. But there are problems like frailty, hearing loss, cognitive impairment that prevent many older people from being involved, or makes them think they can't be involved. Now, a bit of consideration and adapting usual practices can overcome many of these barriers and unlock a wealth of experience and opinion. I personally struggle with technology, as the CHARMA team well know, despite all the help I receive, but there are ways around it. So also language and cultural barriers can be addressed and using translators and plain language and visual aids. So there are ways of involving the older people that you need. Thanks. Next slide, please. I'll go on without the slides there. Where were we?
Can you see that okay still? The slide, is it showing?
Yeah, yes, I think we might, yeah, that's lovely. There are 5 members of the CHARMA team, of which I'm one. We've got a broad range of work and life experiences. We meet twice a month as a group, and all the PPI input is captured and recorded. The members are embedded into each of the work packages and they're linked to other activities. We look at all patient and public facing documents and comment and make sure that they're clear and consistent. And we're actively have our views sought and they're valued. When we attend meetings, we're encouraged to put forward our comments. I think if there were 2 words to sum up CHARMA approach to PPI, it would be support and inclusion, and this is so meaningful. And that means that we can make a meaningful contribution and we can enjoy it as well. Thank you.
Thanks, Jenny. So what we wanted to do whilst we've got you here today is, rather than talk at you for the full duration, is have an opportunity for us to share ideas and think about how we can maintain this momentum, so that we don't all then disband after Charmer. We want to actually maintain momentum and grow over the next few years, so that we really are building research capacity. And I think with Charmer, whilst it hadn't been kind of created in this way, what it ended up doing is it brought together research involving older adults and medicines. And then what that resulted in was that it then brought together geriatricians and pharmacists and nurses and the wider healthcare team, and geriatricians and pharmacists have been identified as underrepresented professions in terms of research capacity. And then, of course, there's then the participants who are older adults who are also underrepresented. So what we were then therefore thinking is this combination of research involving older adults and medicines really is helping build capacity in 3 underrepresented areas. And we know we have with us today some Charmer PIs and geriatricians and pharmacists who participated. So we'd be really interested in sharing now thoughts about opportunities that you think might be out there for you to or others to take forward in terms of research involving medicines in older adults. Please feel free to unmute yourself and pop on your cameras or pop things in the chat. Anyone have any thoughts on what we might be able to do, potentially even with Charmer data? But ideally, we would want to start the building new projects to increase capacity. I can see a hand. I think that's from Christina.
I did. Hello, everyone. So I'm Christina Medlinsk. I'm principal pharmacist at Hull University Teaching Hospitals, and the pharmacist frailty team here at our hospitals. They're quite focused on false risk-inducing drugs and potentially pharmacist-led reviews. They have delivered some initiatives into pharmacist-led and pharmacy team included pharmacy technicians as well, led reviews for reducing the prescribing on FRIDS. So probably there's something we would be interested in developing further.
Sounds good. And what are your thoughts about how you might do that?
I'm not sure yet. We have done some initial quality improvement type of work, which has been received quite well from the pharmacy team, and upskilling the pharmacy team in the frailty. There's still a gap between, I guess, implementing those recommendations for deprescribing. So yeah, not sure.
I love that, and just hearing the quality improvement made my kind of eyes sparkle, because so with one of my other hats is I lead the incubator, the National Incubator for Pharmacy Professionals, to build research capacity within the profession. And one of the things that's coming through is to start small. You know, think about quality improvement projects, think about audits, and from those can grow the research projects, and it builds confidence, and it brings an opportunity then to apply for funds. So I think that's a really exciting approach. And please, if there's anyone, as these ideas are coming through, if there's anyone that thinks, oh yes, I'd like to collaborate on that, I'd like to work with you on that, then please do pop that in the chat, and with your permission we can then link people up. Larissa. or you're still on mute.
Sorry, I should have learnt by now, shouldn't I? Hi, Debbie and everybody else. Just to flag that I am still in the process of developing a CHARMA type study, sort of like a feasibility trial, involving older adults and ambulance independent prescribers, looking at de-prescribing. That's we're kind of working up as a hopefully an NHS RFPB bid. So that's sort of my sort of potential similarity to your project. I was just wondering, because you said CHARMA data, did you, I don't suppose you collected anything related to ambulance data in your CHARMA data set, whether it was like how patients arrived at hospital?
No, we didn't, unfortunately. I wondered, Jackie, there won't be any of that in the linked data, will there?
I don't think so.
No,
I can check and
I'm so
just.
sorry. I know. I'm sure now we'll be like over several years we're going to be kicking ourselves. But no, we have reason for admission, but not how. But there might be something. So I think we might be able to tell whether emergency admissions. So that data could help with. Are you thinking with a background of creating that argument of look at the size of the problem? Yeah.
Yes, because we, as you can probably guess, there is very little out there. So I'm kind of, not that I'm clutching at straws, but it would be any information would be very gratefully received.
Absolutely. We'll have a look, see what we've got.
Thank you.
What sort of timeframes are you working towards?
We're hoping for a submission in the new year. So
okay,
it's a few months.
Most of the CHARMA patients would have been emergency admissions. Do you need to know whether they were referred by a 999 call or GP? Does that make a difference? Or not really? Is it just whether it's emergency or elective?
I think to be able to separate out from the GPs, but I'd be happy to just any information just to kind of give some kind of indication of the scale of the potential problem. That's what I'd be interested in. So thank you.
That's amazing. So yeah, because even then when we're looking now at the data, we could be clocking anything that we think could be useful. I wonder if there's something in that, like if we could, as a community, if we could somehow log, does any, and when the QI projects are happening across the country, could we have set up something where we just say, does anyone have anything to support? This is my idea. Does anyone have anything to support it? It could be an opportunity then for us to come together.
Definitely. I mean, the thing is, we're quite often where we're normally forgotten. So I don't expect anybody to collect ambulance data, but once you start asking the questions, we just kind of raise our profile, and we are part. We don't have to tell you, we are part of the care journey. So all the any information would be very much gratefully received.
Thanks, Larissa.
Thank you,
Sharina.
Hi, this is not necessarily medicine optimization, but with my perioperative oncology hat on, for example, we do research around reduced dose chemotherapy for older people, which I think is really important. Sometimes it's either that or they are completely excluded from cancer treatment. Another thing that we also do, things like heart failure management. The standard NICE guideline says you have to have X, Y, and Z, but not all of them can tolerate all of those drugs, and it's about looking at how we tailor it appropriately for our frail older people. And this is where I think it's definitely there's a large degree of sort of inequity.
Oh, Victoria?
I was just going to respond to Sharina's point there and just say that as a community, obviously I put the slide up with the aging studies at the bottom being relatively few and the cancer studies at the top being the dominant type of portfolio studies in terms of specialty. But in our clinical practice as geriatricians, we very much work with other specialties. We have really shared care models, like in orthogeriatrics around perioperative care, and in some centres around oncology as well. And there's no reason that should not be reflected in the research. And I think there needs to be much more sort of collaboration between, clinical academic geriatricians and also people delivering research at the ground level and other specialties to kind of design these studies in areas that might not necessarily be seen as aiding research, but nevertheless have those really important questions about how can we personalize treatment and get the evidence in the not just older adult population, but often people living with multiple long-term conditions, which may actually be the bigger issue than age itself. It may be the interaction of all those medications with different conditions and different medications that requires the personalization. So just to think that the research in a way needs to reflect what we do clinically. We all work together. We're not actually in these silos, or we shouldn't be.
Thanks, Victoria. Julia?
Hi, Debbie. Thank you. So there's so much we can do. I mean, it's really exciting question. We now have the reporting capabilities across all sites, and I think some of the QI work that we've been doing looks at kind of pre-admission versus discharge meds. There's possibly a learning piece from that, as in which groups of drugs perhaps we are more confident prescribing versus which ones we are not, and perhaps a bit around education and maybe furthering our competencies with regards to appropriate polypharmacy reviews. I thought also it would be interesting to think about patients' perspective versus our clinician perspective with regards to what we do whilst people are in hospital. But there are so many underrepresented areas, and I think this is a really rich sphere for us to all put our heads together. I think really needs to put in the comment box. Maybe we could have a QI collaborative where we share some of this. I know there's one on the BGS hub for people that kind of send things through to the British Geriatric Society, but it'd be really helpful to collaborate more in terms of meds op, because there is huge amount of unmet need and unanswered questions really within this patient population.
And even just with, as you said, the data that you collected associated with trauma has led to new research questions.
Absolutely. I mean, it's just analysing the monthly data sets, because what I've got is one of my resident doctors does a 20 patient sample from each month, and we just look at trends, and we look at what it is that we're doing in terms of deprescribing, what is it that we're starting with our patients, and then it'll be really interesting to then compare our clinician and patient perspectives with regards to where we end up in terms of our kind of polypharmacy reviews. I'd be really keen to kind of progress that with any other colleagues who may have an interest.
Oh, thank you. We'll go to Graham, and then Veerle, I know you've got your hand up and we've got some comments in the chat. We will hopefully be able to pick those up towards the latter part of the session, but I'll hand over to Graham now.
Thank you very much, Debbie. Just wanted to chip in a couple of suggestions. Firstly, there's a rising interest in the training and introduction of non-medical prescribers into the prescribing portfolio, if you like. And I do have some concern that most of their training is about starting and initiating and using new medicines, but that should all include what happens at the other end when it comes to stopping and minimizing the unnecessary burden. And perhaps there's some research opportunity around non-medical prescribers and introducing some of these concepts.
Super, thanks, Graham. Okay, lots of exciting ideas, and I'm looking forward to picking these up towards the latter part of this session when we'll hopefully have a bit more time. I'm now going to hand over. Oh, sorry, Graham, was there something else?
Again. Yeah, sorry, I'm back again. So I hope you got most of that.
Yes.
The second one was I never cease to be amazed by how much older people know about what's going on and their increasingly complex lives and balancing mental health and physical health. And perhaps there's an opportunity to create some research that's much more patient-led in terms of defining and designing clinical studies that involves their needs and is driven by all the expertise that's held within older people. And it might be really exciting to have an older person's led piece that is enabled through
No,
academic.
thanks. And that picks up on some of the comments that Jenny made in her presentation. So perhaps we can bash some of that out a little bit at the end. So I'm going to now hand over to Dula to talk about her journey.
Thanks, Debbie. So I'm Dula. I'm a consultant frailty pharmacist based at Brighton Wigan and Lee NHS Trust. I also co-chair the pharmacy group for the British Geriatric Society. And I'm just going to have 5 minutes to talk about my perspective of being a principal investigator within an ageing research specialty study. Next slide, please. So just to kind of give colleagues some background on pharmacy and research, it is one of the 5 pillars of practice as defined by both core advanced pharmacist curricula and obviously consultant pharmacist curriculum. We are the 3rd largest healthcare profession, as Debbie's already alluded to. We are underrepresented in terms of research participation. And from the NIHR incubator findings, 3 areas of focus are currently being looked at. So embedding research as part of professional identity and practice. And I certainly know that there are barriers in terms of job plans and being able to do this as part of our kind of normal day-to-day jobs. Beliefs about research and its perceived value. That is still something that obviously needs addressing, and creating a research community. So obviously today is great because we all get a chance to talk about our research ideas and our kind of smaller projects, hopefully leading to other things in the future, which might be more collaborative. Next slide, please. In terms of my own CHARMA journey, I was here at the beginning back in 2021 from the core outcome set work package 1. So obviously that involved basically having participants from different backgrounds, including managers, which I thought was a really good group to consider to define what we should measure when we are completing deprescribing studies. We were then involved in the feasibility study as the work package 3, and then finally in the full trial from 2024 into 2025. Some of the things that I think CHARMA has had an amazing legacy in terms of what we did, kind of as part of our journey. We redesigned our ward round notes so that we have a checklist that basically says deprescribing discussion complete, and I think that helps to concentrate our minds on very busy ward rounds to actually make sure that we are considering deprescribing, and obviously we're ticking that box when that conversation has happened with our patient. As I've already mentioned, we now have amazing reporting capabilities, so I can run pre-admission and discharge meds for all of our aging and complex medicine wards, which allows us to stop and look at trends, look at training, look at things that we are perhaps doing well and things that where we need to put some work in. And I put this in bold because I think it's really education and empowerment is the strongest legacy of us participating in CHARMA. Having that cross-sector involvement where the pharmacists who are covering our kind of older adult wards are involved and participating in research. I think as we've already mentioned on the pharmacy incubator, it's a great incentive for us to kind of embrace research and obviously geriatricians as well as our patients. So all of us really being educated and empowered to take things forward. And on the right hand side is a video of us doing a World Pharmacist Day promotion of CHARMA back in 2023. Next slide, please. So in terms of my own personal benefits and career enrichment, so I did do my credentialing as consultant pharmacist back in June 21, so at the very beginning of my CHARMA journey. It has certainly helped in terms of progressing my applications to become a senior honorary lecturer at our local higher education institution. I've done lots of teaching locally, regionally, nationally, and also to international audiences. And I really have used quite a lot of the information from our CHARMA slide sets at various forums. And I think this is just a kind of a screenshot from what we did over at the Royal College of Physicians in June, and we were really talking about the challenge of inappropriate polypharmacy, and again trying to take that conversation not just to geriatricians but to all the physicians, all the medical specialties, understanding that more than 50% of older people are prescribed at least one potentially inappropriate medicine, and that only a small percentage of those are actually stopped during hospital admissions. Next slide, final slide. Sorry, I know I'm on 5 minutes. So just in summary, from my own personal perspective, it's such an important research question. How can we become more proactive in terms of stopping harm from medication from occurring? So I feel that's been a huge benefit of participation in CHARMA. And as I've already said, very much kind of confidence in terms of whole team coming on the journey of patient-centered reviews, documentation of what we're doing as part of our ward round note, and the data analysis to help us keep driving the issue forward. And that's everything from me. Thank you.
Amazing. Thanks, Julia. And now I'm going to hand over to Sharina.
I think it's marked before me.
Oh, apologies. Apologies.
Yeah.
It's not. I'm really sorry.
I'm sorry for you, Sharina, but I take it as a compliment, so thank you. Hello everyone. I decided not to do slides. I just want to share some of my experiences, and firstly thank you to the group for allowing us to support you with CHARMA. And obviously we wanted to make sure Liverpool Voices and Liverpool patients were included in this, because obviously we're going to be very passionate about our patient sub cohort. I just wanted to sort of say why I became a PI, what my experiences were, the good, the bad, the ugly, my thoughts on what you need to think about when it comes to going forward. I'm unapologetically a pure clinician by background and not an academic geriatrician, and I trained in an area where you were told you're a doctor and then you choose what you want to go into. You could be an educator, a leader, or an academic, and I for my sins decided to become a leader, and I've had the fortune of inhabiting lots of senior leadership positions, and traditionally a person who's here to actually drive through some of the changes. And just like a food critic, I'm very involved in peer reviews and tearing apart and looking at the good, the bad, and ugly in research. I wanted to actually see what actually happened in the kitchen, quite selfishly, to see how these meals are actually cooked and see if there's more we could learn from that. And you find yourself getting to your 40s where you think, well, just because I've not been involved in research before, do I still have a role in supporting this going forward, or is it only the select chosen few who have been blessed at a young age that are allowed to do academia? And I think that's the culture in which I've grown up in, and still to this day I see doctors in geriatric medicine turning around to those who want academic posts and say, so why didn't you want to become a proper doctor? And I think we've got to consider the perceptions of academia and how we change it, because it's an extremely important role. And actually, all of us should be contributing to research in academia in our own way. And that's something I'll sum up of in a bit. So that was my initial background. And for me, what was the main driving factor is this is a priority topic, isn't it? This is something we're passionate about. If the topic was, let's do a study on drugs on protein 12546.56 levels, I'm not going to engage in that, because that's not going to save the world. So I think it's always got to be about what's going to drive change, and that's what's going to inspire particularly pharmacists and geriatricians. I also want to challenge my team, because we sadly haven't had a chair academic seat in Liverpool University Hospital since the late 90s or early noughties, and it's something we've de-skilled as locally as a team, but yet we've had other dominant voices in research locally. And many of you will be aware we have a very strong clin pharm group who dominate and gobble up anything to do with pharmaceuticals. So we wanted the trust to reconsider the importance of geriatric medicine and truly use this as a learning experience. And not for me personally, but for me to inspire my team to take up the mantle going forward, that academia can be fun, contributing to these sort of studies can be good for the department and for the wider population going forward. So that was the sort of the why for what it makes sense. And for me, the benefits were obviously it clearly inspired change within my group, a feeling of actually contributing to the evidence base. And it was so lovely seeing those summary slides up before of the scale of it, because I'll be honest with you, I feel like a fraud. I don't know what I've actually done, but those are lovely slides, so that's great. It increased my skills personally and also the skills of the wider team, and it's good for us again to increase the academic output for our patients and in Liverpool. And I said to you before about the joke about perception. If I've took one thing away from this, is my respect for research nurses and research teams has gone up exponentially, because I used to think everyone that did research was just having a holiday and having a DOS, and it is far from it. And one thing I'll tell you for a fact is I wouldn't have got over the first hurdle with my team if it wasn't for a skilled research team who have the dedication and the training to do that. And we were really lucky in Liverpool that we've got this absolute mammoth of a team. And through this if there's one benefit as a secondary outcome, we've got a new relationship with our research team, which we did not previously have. So I think that's fantastic. So there's loads of good things I could go on about. The challenges are, for me, again, you know, I'm used to dealing with politicians, the courts, colleagues, everything else from a leadership point of view, but I was not prepared for the legalese world of research. My God, my head was spinning, non-substantive, substantive, amendment, this amendment, that. I thought I was in the Houses of Parliament. I'll be honest with you, they came to a point where I thought, I'm just going to put this in this box and hope it vanishes. And I think that's something we need to reflect on, in that I don't think there's any shame in sort of skill checking and humbly asking PIs as well. Do you understand this? Or, you know, what, you know, is there bespoke support that others need? Because no one's ever going to sort of put their hands up and say, well, I feel a bit out of my depth here. But again, having that research team for me was fantastic. But it can be intimidating. You know, I'm a senior NHS consultant, but even I found it quite intimidating. There's obviously a lot of email traffic, as you know, and setting up filters, and the central team have been really fantastic. I think you've already said before, you know, it can feel isolating as a PI at times, and it does take a lot of time. And there's a lot of characters as well from the Charmer team as well, and it doesn't seem to normally be the natural environment of a geriatrician. And as I've already alluded to, you know, there were times, and I'll be honest, there was times I thought, I can't be bothered doing this. I might as well just give up. You know, it's like, what is it actually worth all this effort? But if you were to ask me what was the thing that kept me doing it, it was the validity of the topic, but also the commitment of the group on why this was important that got me through that. But I would be lying to you if I didn't say I want. You know, there was a part of me that said I can't be bothered doing this, and I'd be curious if anyone else felt the same way. So for me, what I would advise you as a group consider reflecting on is we need to change the perception of academia and research, particularly with older people, because it's an important cohort of patients. You know, to use a term, we need to, you know, make research sexy in a way. And also, we need to make a decision, and that is research for a select few of those who have got the skill set and the expertise to do it, or how do we engage more coal-faced geriatricians on the shop floor? And also, we need to have an honest conversation about what everyone's skill set is. Do I think I'm the world's best PI? No, I don't. But I think my skill set is, if someone puts a paper in front of me saying, well, this is what Charmer shows, well, I'm the man you put in a room to make it happen. And I think we need to have that strategical awareness as a research group as to who's good for what task. And that's conversations we need to have locally as well in geriatric medicine. Who's got that research skill set? And maybe sites that are already more established research acting in a mentorship role for those that are more research naive as to how they can piggyback and gain those expertise, because trainees want these skills as well. And if you've got a consultant body that don't have that skill, how do we generate the future vision for that? I think the topics need to be relevant. This one is, that's why I was so passionate about it. And we need to shy away from any research that's very boring and will not lead to clinical change. And the last thing I'll say is that I think from a central point of view, having that single point of contact is really important, because the noise can be very confusing, and it's sometimes easy just to switch off and go, I'll just ignore it, and then hopefully someone who really needs me will comment me. And lastly, the bureaucracy of commencing projects as well is very, very onerous. We have many projects and ideas, and to actually get it even started is a challenge in of itself. So if we create toolkits that can be shared nationally, whereby, you know, look, this is actually how you do it. It may be something really humble, a little QI or an audit. But you'd be surprised how many people are put off even starting that good work. So that's my vision of the world in a nutshell. I saw some nodding heads, so I hope that's helpful.
Thanks, Mark. So that's half a dozen things you've given us to work through at the end. Sharina.
I'm not going to go through my presentation because I think lots of it was already covered in sort of the last, a couple of presentations earlier. I just wanted to point out a few things and add a few more comments. So I was both the research team and the PI. So, I was doing the data collection, etc., consent and all of those things. And partly because we didn't have a research sort of team to deliver the research. Some of that is because of financial constraints, I think, which is probably not unusual across lots of other trusts. I'm research lead for my department and slowly trying to grow our research portfolio. So saw this as an amazing opportunity to take part in research. I think we were very lucky that with our pharmacy colleagues were absolutely brilliant. They're very supportive of the work. They drove a lot of the intervention, and I'm incredibly grateful. And we continue to try and work together and collaborate on sort of any sort of research projects within our hospital. Just a few other things. I think we also need to get older people interested in research. I think a lot of the time when I went to consent people, they said, well, I don't really know, I don't really think it's going to add anything. And I think we need to get that enthusiasm and sort of momentum and tell them why it's important. So for example, on our sort of the International Older People's Day, we need to try and engage them and try and explain why it's really important, how they can contribute, why is it important to take part, why is it important for us to value their sort of opinions, their sort of feedback, etc., and all of these things. And it's about raising that engagement profile, I think. The other big thing for us is, I think, executive sort of buy-in. So I'm currently part of an NIH HR project looking at POPs2. I think Mark might be part of that project as well, looking at how we can optimize sort of medical conditions in older people undergoing surgery, where we needed sort of executive buy-in, because that's the only time where we're going to get the support and sort of financial commitment of a lot of these things. And my final comment is just to echo what Mark said. There's very few academic geriatricians around the country, and in my late 40s now, I'm not going to undertake a PhD, for example. If I were 10 years younger and I had the opportunity, I might consider it. And it's about, maybe we can think about a shortened program of support and mentorship, a bit like your Mary Seacole program through the NHS Leadership Academy, but on a research basis, so that some of us can go through this sort of mentored program and think about how we can then get more people on board. And I think that'd be a really exciting opportunity, because if you take, say, 3 or 6 months, alongside your clinical work to do something like that, I think that would grow sort of the research potential just nationally. Thank you.
Thanks, Sharina. I know we're moving into the discussion now, but can I just clarify one thing? You mentioned this kind of leadership program, 3 to 6 months. Are you thinking then in terms of equipping people with the skills to then become research leaders, or to support delivery?
I think both. I think you need the knowledge, and you need that leadership experience, and also understand what is research delivery. And I think it just makes you a bit more research ready.
I'm thinking with the delivery, there's the associate PI program.
Okay. I wasn't aware of that.
No, okay. Well, that in itself is useful. Yeah, and then research leadership, there's nothing.
Okay. And I mean, the other thing is, it's difficult because I think I don't know whether these sort of programs are limited by numbers, or how does it work. I know, for example, my trust had like a leadership program, not about research, and again, the numbers were capped. Not everybody had the chance and opportunity of attending. It's about lots of dates don't fit, and it's about I think looking at some of those things, the logistics of how we deliver this.
Oh, thank you. Oh, I can see Martin wants to come in. But before you, Gina or Lizzie, do we have another slide for the discussion? Because I think that's where we're going. Yeah. Martin.
Oh, hi everyone. So I'm part of the JAMA team. I'm also, as I put in the chat, the NIHR East of England Aging Specialty Lead, which is a mouthful. But the Associate PI scheme, it's great. I'll put the link in the chat. It's quite easy to navigate the website. All you need to do is find one person in your organization who's happy to mentor you, and then you find a study that you're interested in. Most NIHR studies are happy to open second sites. They need lots of sites in NHS hospitals, and you get somebody who's got the research experience to talk you through the process whilst getting the experience of working through a study. And it also builds in some lectures and webinars and training within it. So it's a really good scheme. It's open to, I think, pretty much anyone. So do have a look at that. There's lots more.
One of the problems, sorry, Martin, one of the problems is that the PI themselves, or the CI, sorry, they need to register the study as an associate PI study as being part of the scheme. So that can if we've got CIs who perhaps aren't aware of it or whatever, then we may have studies that could be fantastic within the aging portfolio, but no opportunity to engage with that. Okay, so many amazing, really inspiring talks. I think I've got lots of ideas that I think have come from that. So I'm going to now throw it out to those here. What are your thoughts on on how we might go about increasing capacity. Heather.
Hi, just listening to what people were saying and really interested in what Mark was saying about skills. So for people who don't know me, I'm a consultant pharmacist in older people, and I'm involved in quite a few NIHR projects, which makes me sound like I know lots about research, and I don't. So I'm basically there as a clinician and sort of giving a view on what might work in practice, and that's my skill set. And that's the skill set that I think all the geriatricians on this call will absolutely have, even if they maybe don't know much about research methodology. I have to say I did do an MSc back when I was 25, so that was an awful long time ago. So I had some knowledge of research, but actually I just kept turning up to the universities like a bad penny until somebody thought, oh, maybe we could use her, and that's how I got involved. But I think there's something that we could do with this group to really link researchers and clinicians together. And I think the great joy of CHARMA and the great benefit of that is that we actually then do research that we can translate into clinical practice to make practice better and improve outcomes for older people.
Thanks, Heather. Any other thoughts, comments based on what we've heard, or anything you wanted to share? Victoria, you don't need to put your hand up. You're facilitating this bit.
I know, but I'm aware I talk a lot, so I'm trying to be trying to be really reserved and let other people speak. It's really what we want to hear is from the wider group. But I just wonder sometimes that there needs to be that institutional commitment at the top to support this aspiration. And we did hear a bit through the talks about a lack of a chair in various big academic centres representing ageing, and that sort of feeling then that trickles down that it's not important and it's not for us, and that kind of feeds into the culture, both from the patients and from the workforce, that this isn't something that's a priority for us. It's not going to make a difference because the institutions aren't committing to it. And I just wonder if there are any thoughts about how we can address that, how we can maybe better represent ourselves to get that representation, to use the vehicles that we've got either through the BGS, the NIHR, to actually get that representation, what people think about that. Getting it in, for example, in oncology, a lot of oncologist job plans will include a PA for delivering research trials. There'll be a lead at each centre for delivering portfolio studies, and they may have that built into their job plans, which I don't think is normal across, for example, consultant geriatricians or pharmacists' job plans. But I'd be interested to hear from the group, because I've only got my own experience. It's a wonderful opportunity to hear from other people. I'm sure I saw some hands. Martin's got his hand up.
Unmute. This was discussed just a couple of days ago at the National Aging Leads meeting. We all get together from all the regions, and it seems to be a problem. Geriatricians just don't get paid to do research. It's really hard to engineer to be paid to do research in the current financial climate where hospitals are making people redundant, not wanting to pay people to do more work. The one person was the chap from Wales who had one PA in his job plan for doing research, and the rest of us jaws hit the floor when he said that, because it's just so unlikely for a geriatrician. And that equity you say about oncologists being paid to do cancer studies, we want to bring ourselves up to the oncologists. We don't want to drag them down to us. We want everybody to have time to do research, because research culture makes for better clinical outcomes.
So without wanting this to be a conversation between us, Martin, and without wanting to name any particular centres, I have seen a kind of board priority setting document at a fairly large district general hospital, which really put research right up there at the top of that hospital's agenda. And they were willing to pay for research PAs for a geriatrician. So, I think there are some communities out there who are receptive. It's just about finding them and kind of, the national picture is really difficult. But if we don't ever ask or push, we're never going to get.
Well, I agree.
Fortunately, someone else has put their hand up, Claire.
Yeah, I was just going to kind of reiterate that point, really. I mean, I'm really lucky because in my department, I've got an interest in research, but no big.
Claire, you're very quiet. I don't think
Yeah,
anyone
you
can hear
broke up a bit because you said, oh, I've got an interest in research.
I've got an interest in research. Can you hear me?
Yeah,
that's better.
Yeah, that's better. Sorry, I've got such a dodgy mic. Yeah, I mean, I'm too old a geriatrician to have been through an academic training program, but I have got an interest in trying to enable research, and I've been really lucky that our departmental lead had given me some time, because I don't think I could have done it without that. But our research, our head of research in the hospital, they are really interested in helping and supporting older people's research, and without our agile research team we wouldn't have either been able to do it. So we kind of had both of those things lined up, and I'm so in admiration of those that have done CHARMA without some of that support, because it's not possible for most studies or most people. So I absolutely agree that we've got to kind of build that capacity. And it's, I mean, you know, it's most of the patients in the hospital, isn't it? So it does need to be increased in terms of its importance.
Yeah, so that's a consistent message that's coming out, that actually that influences a lot of these factors that we're talking about, which is that raising awareness within the patient population, raising awareness within organisations, raising awareness within the professions, so that then the infrastructure and the funds follow. Velin?
I was just going to say about increasing capacity amongst the patient population and the different healthcare professional groups as well, because, you know, with CHARMA, it was really good that, you know, it was a collaboration between the geriatricians and the pharmacists, and we can both kind of try to support each other. Because, for example, in my clinical practice, so I work with Sharina, so there's one geriatrician or two geriatricians who are, you know, research active, and then there's one or two pharmacists who are research active. So it's one person in the whole department. It's really quite challenging, and it's kind of about upskilling the whole department, isn't it, I think? I just wondered about Victoria's example. I think something that Martin said was, I thought, quite good, because I think that there are lots of kind of interested people around working in large departments, but one person, like I said, so there needs to be that drive of research leadership almost. I wondered whether there are centres that are having really positive engagement in research and really high output that we could maybe use as a model for others to kind of model against, because it's about engaging with the board, engaging with the trust research department, and then bringing that back to your own geriatric department, and then cascading that downwards and having regular research discussion. Because, you know, these kind of discussions we don't get to have very often. So I think, yeah, it's just kind of that whole infrastructure that needs looking at, maybe.
So I think that perhaps there's not always a lot of lived experience of what infrastructure there is to support the research through the different hospitals. Like every hospital will have a research R&D department, research and development department, they may call it something slightly different, and a sort of way of enabling and managing research studies. I've just moved from Cambridge to Exeter. For example, in Cambridge, one thing that was quite a simple thing that was quite important to me facilitating research was getting an account in R&D for the money to go through, and building up a relationship with the R&D staff, that when I contacted them about a study, they sort of knew who I was, I knew the right person to contact over time, we worked out all the processes, and it sort of made it a lot easier. And then also putting research on our clinical governance and our departmental service centre meeting minute agendas. So there was actually at a departmental level, we then discussed the research projects that were going on from a governance perspective and also a sort of service activity perspective. So it just kind of disseminated that knowledge out to the rest of the department about what activity was going on, who'd taken part in what. And then having moved to Exeter, what I'm learning how they work here, there are various academic departments within the hospital, and it's kind of, you have to apply for that. So you might not realise what's going on, but you could tap into various resources that could support and facilitate research. But it may be that in some places the departments just aren't aware of what they could tap into. Do you sort of see what I mean? It's that's the sort of that's what I think we're talking about in terms of this lived experience that people have built up through participation in CHARMA. They suddenly know who to contact and how it's beginning to understand how it all works. That's what we don't want to lose. And it's just those small things that disseminate out knowledge across the wider workforce. And then it becomes part of normal practice. And that's how the culture gradually changes. That culture with that is a more societal issue, not just amongst the workforce, but these are small steps, can be quite important.
So Mark in his talk threw out, and it wasn't just Mark, there were others that threw out a number of things that may be tangible things for us to take forward. So one of them was relevant topics. Because he said, I can't remember what fictitious.
But if that protein is suddenly the cure for aging, that's going to come back to bite him. If one day someone discovers that protein 1.2468, whatever it was. Yeah.
So relevant topics, and I wonder if we've already started to do some of that. In that, we've got ideas floating around here, lots of them. How might we support making that happen? Does anyone have any thoughts on the practicalities of being able to contribute to generate relevant topics? Phelan?
Sorry, I was just typing that in the chat, so I might as well say I was just thinking about in other kind of research area, they do kind of research prioritization setting kind of exercise through Delphi consensus. And I wondered, this group of people, we've got lots of ideas to generate, whether we want a list of, I don't know, top 10, top 20 things that we want to focus on type thing, that we can all kind of contribute to it to kind of build capacity. An idea.
Yeah, we could establish, and we between us have lots of network, so we could establish something, and that then feeds into this raising the profile of research within the ageing speciality. Thanks, Phelan. Another thing that's come up repeatedly, so Sharina mentioned it, Mark, I think pretty much everyone's mentioned, to a certain extent, mentorship. Any thoughts about how we might address that, what it might look like? It's a bit of a chicken and egg, isn't it? There aren't many about. And those that are then stretched very thin. Martin?
So my home hospital, Norfolk and Norwich, runs a research mentorship group. So probably the simplest thing to do is the organisation you work for, ask your R&D department, do they have an equivalent group for research mentors? I'd be surprised if there wasn't anything in place to take someone who was just expressing an interest in research and give them a point in the right direction. You'd hope there would be. So yeah, that would be my first suggestion. And if it doesn't exist, demand they create it.
Christina?
I was just going to add, I have been mentoring in my role colleagues at different levels and different involvement in the research. And I guess you as a mentor would be maybe good to have some sort of a guidance in the way, like what would you expect the newly qualified or quite very early careers researcher to be able to do after your mentorship? So would that be like come up with a project, submit for, I don't know, abstract for conference presentation, being able to do those skills? And then what level would you be expecting your mentee to achieve? What if they are a bit, further into the research career, maybe they are at the consultant level or moving from advanced to consultant level? So sometimes when you're mentoring, it seems like, I don't know, well, it's not supposed to have it, but to see like what is your impact, like what is the impact that you have would be expected at that level.
Yeah, I guess I don't know. Yeah, I guess we all need to start somewhere. Does it matter at what level we're at in our clinical role?
I think that the advantage of a clinical academic career is that it doesn't have to be as restrictive as maybe a traditional academic career. You can dip in and out of it because there's a recognition that you may have times in your career where it's really important to hone your clinical skills, whatever they may be. And then there may be other times that it's appropriate. You've kind of leveled off in your clinical trajectory and you can spend some time doing a research project, and actually it might be appropriate because you've actually developed an interest and an understanding about what the unmet needs are in that particular area. So I think a clinical academic career, and again I use that term really broadly to include all sorts of practitioners involved in care. You can dip in and out of it. In a way, it's a bit of a luxury in a way that perhaps other academics can't. But I think when I talk about capacity building, I'm really talking a lot wider than just the traditional kind of clinical academic careers. I'm talking about also the delivery. How can we just do what the RCP want and the NHR make research everybody's business, and make sure that our workforce and our patients feel included and don't have that really depressing comment that was made by someone, I can't remember who it was, that the older patients just, what's the point? Why bother with us? That's not right, because we know we can do things better. We've had big advances in how we look after older patients over the course of my career. We didn't have, orthogeriatrics when I first started. We didn't have stroke thrombolysis. We didn't have such clear conceptualization of frailty as a clinical entity and comprehensive geriatric assessment. We didn't understand the benefits as clearly as we do now of different service models and different treatments. So I think, that sort of comment that it's not for us, what can be done, that's the culture that we need to change.
So where do we go? We've talked about so many things that are clearly really important for us to address. Where do we start? What would you like us to do next? Is something like this a useful thing? To try and take things forward, or is there a different mechanism that you think might work better? Probably should have done a poll, shouldn't I? Because there are so many different things for us to take forward. Can I just see like anything, just give me like impressions or whatever do we do another one of these? And then the other option is going to be, should we put together almost expressions of interest for doing smaller group stuff? Another one of these big things? Oh, big.
Sorry. Don't want to speak for the sake of speaking, but I just wondered whether, I don't know if everybody who's invited to this webinar managed to dial in, and whether it would be good to send out a summary of, what was suggested, and then do a poll maybe on email, because it's quite an easy thing that they could just push a
People
button.
reply. I get that's something. Why we're all here.
It's tricky, isn't it?
Yeah.
But you know, I think there's going to be some self-selectivity, I'm sure.
But
But
what you
it's
have
somewhere
made
to
me think
start,
is
I
you said
guess.
that not everyone will have had an opportunity to attend. So perhaps another smaller one of these, a very small focused one, that then might allow us to then think about what the priorities are and how we go about addressing them.
I mean, there is quite a lot that's been talked about to digest. My feeling is always that we can beat the drums at the ground level up, and that's really important. But we also need to get some buy-in at the top from, to get that institutional commitment. For, otherwise the drum beating gets tiring, if it's falling on deaf ears. And that's why I'm not sure exactly where we would go at the top, but it would be interesting to hear people's thoughts. Because I think there does need to be more commitment to facilitating interested. It's not mandatory that you have to participate in research, but it should be an aspiration, and it that every department can participate in research if they want to. And as a specialty, we are committed to delivering evidence-based care just like everyone else in the NHS. So we need to contribute to that. But if you're not being allowed to do that by your institution, that is tricky.
Yeah, and I can see someone put in third sector, various third sectors, and DHSC. We could potentially get them to come to another session.
Yeah, that we need some key stakeholders here who can actually, hear what people have really just. I thought that some of the presentations were so passionate, and there was a really common theme. Particularly between Mark and Sharina's presentation, but also all the presentations really spoke to the same tune, didn't they? And it would just be so great if we could actually get people in the room to hear that, who could potentially help us with a way forward at the top. We're really happy to beat the drums at the bottom, but someone's got to be listening.
Jackie, did you want to come in at all?
Yeah, I was just going to say that there were some people that couldn't come today because of other commitments. So there is a lot of interested people out there apart from the people that joined us today. So I think if we can circulate this recording and a summary of what we've discussed and sort of get more input, I think there's quite a lot of passion to do more in this space, which is great.
Yeah, I'm thinking, can we put together some sort of a summary document and send it to the DHSC?
Yeah.
So that they're aware of the inequity.
Yeah.
Anything else from you, Jackie?
I was just going to sum up at the end, but are you at that point?
I think we are. I don't know. Are you, Tommy?
The only thing I was going to ask just the room was, is there anything that just jumps out at you as the next step that would be practical and sort of helpful? And it could be that it's another webinar and we build on this. I just didn't know if anybody had any thoughts. No. Well, I'll sum up. Firstly, I'd like to thank, on behalf of the CHARMA team, I'd like to thank everyone that's been involved with us on the various work packages over the past 5 years. As Debbie said, it's such a large program of research and we couldn't have done what we've done without your dedication and input throughout. I'd like to thank all our speakers today for such interesting presentations that really stimulated the discussions that we've had. And I think we have got some ideas of how to move forward with increasing capacity within ageing specialty research. We feel that we have developed a community of those that are interested and passionate about ageing specialty research. And we really want to keep this momentum going and grow the community. I've just written some notes as I've gone through the session. that there are definitely opportunities that we could look at. So as I said, there's definitely this interest within the community to do more research. But we need to raise awareness of the importance of doing this research in this space to enable funding opportunities and to increase support from higher up within the trust. We need to change the culture of doing research and include mentorship. And we discussed identifying whether there's mentorship schemes available within each hospital. We could look at identifying priorities for future research in this space. There is definitely came through today that there's a need to have equity for those involved in older people's medicine and to have similar research opportunities to other specialties. Also came through about building skills and confidence within this community because some people are new to research. The opportunities aren't as readily available as other specialties. For example, how do we tell people about the associate PI scheme? We need to involve other key stakeholders such as DHSC. And also there's a real desire to create communities of practice for QI, but also different specialty topics, and we can definitely push that forward. So we will be in touch to build on this. So as Debbie said, we'll do a summary. We'll circulate this round with the recording from today. If there are others that you know that would have liked to have attended but couldn't because of other commitments, please ask them to get in touch with us. And if things come up after the webinar that you think, you know, we should be thinking about and should build into this summary document, please do get in touch with us. Because, yeah, we do want to keep going with this and keep the momentum. So I'd just like to thank everyone on the call for your input today. Yes, Phelan, good point. So yeah, do keep in touch with us, and we will definitely be in touch with you soon. But thank you.
Amazing. Good to see you all. Thank you very much.